This meeting is being recorded.
You can start.
Okay, so on behalf of IAP Pune, I welcome you all to this 8th session of PG Clinic case discussion. Today we have Dr. Vinit Rathod from Postgraduate Institute YCM Hospital, and he would be presenting a cardiac case. And his guides are Dr. Ambike Madam and Dr. Suryakant Mullur sir. We have two faculty for this session. Dr. Rahul Saraf, who is a pediatric cardiologist, who is attached to Jupiter Hospital, and we have Dr. Vijay Kumar, who is from Belgaum Institute of Medical Sciences. He's associate professor there, senior pediatrician. So I welcome you all. And Dr. Vinit, I think we should get started with the case.
Yes, sir. Good afternoon, everyone. I'm Dr. Vinit Rathod. I'm going to present a case of 5-month-old female child, first by birth order, born out of a non-consanguineous union, Hindu by religion, Yadav by community, resident of Maharunge, Pune, hailing from Bilaspur, Chhattisgarh, informant being mother. She's fairly reliable, brought with the chief complaint of cough since 2 days, fever since 2 days, and fast breathing since 1 day. History of presenting illness. Baby was apparently all right 2 days ago when she developed cough, which was acute in onset, gradually progressive, dry in nature. It was more during feeding and was reduced on putting the putting the child on the shoulder. It was associated with fever, which was acute in onset, gradually progressive, intermittent in nature, high grade, relieved on medication. Child was irritable in interfebrile period also. Mother also complained of fast breathing since 1 day, which was associated with increased irritability and inconsolable cry. On further inquiry, mother gave history of a suck-rest-suck cycle since around 1 month of age, which was increased over last 2 days, due to which the child was not able to feed. There is a history of slightly bluish discoloration of lips since birth, which gets aggravated while crying and reduced on calming down the child. There is no history of recurrent fever, cough, or cold. There is no history of vomiting. There is no history of repeated nebulization in past. No history of decreased urine output, facial puffiness, and abdominal distension. No history of seizure and focal neurological deficit, and no history of breath holding or unconsciousness. Past history. There is no history of similar complaints in the past, no history of recurrent admissions, or no history of any chronic medications in past. Family history. Child is a firstborn of a non-consanguineous union. Yes, sir. And no significant past history. Birth history. In antenatal history, mother conceived spontaneously at 25 years of age. She was ANC registered. Antenatal scans were not done, and iron and folic acid supplements were incompletely taken, and 2 doses of injection TT were received. There is no history of fever, rash during pregnancy, no history of any other drug intake, and no history of diabetes mellitus and any major illness. Perinatal history. The child was a late preterm 36 plus 2 weeker, vaginal delivery, cried immediately at birth. Birth weight of the child was 1.8 kg. Baby was shifted to NICU and was admitted in the NICU and required oxygen since day 1. Baby was started on RT feed on day 2. Relatives were told that baby had some cardiac issue, but baby was not evaluated for the same, and as relatives took DAMA on day 4. Postnatal history. Child is exclusively breastfed until now. Parent have noticed poor weight gain, but no treatment was taken for the same. Immunization history. Child is incompletely immunized, only BCG scar present, no other vaccines taken. Dietary history. Child is exclusively breastfed 4 to 5 times during daytime and 2 to 3 times during night time. And child require almost total of 20 to 25 minutes for each feed, with intermittent stopping in between. Developmental history. Gross motor milestones. Neck holding was present at 4 months of age. Fine motor milestone. Bidextrous grasp at 5 months of age. Social milestone. Social smile was achieved at 2 months of age, and patient could recognize mother at 3 months of age. And in language, cooing was present at 4 months. That is, patient is developmentally normal for the age. Socioeconomic history. According to the modified Kuppuswamy scale of socioeconomic classification, the family belongs to upper lower class. Summary: 5-month-old female child, first born of a non-consanguineous union, with cough, fever, and increased respiratory effort since last 2 days, cyanosis since birth, history of suck cycle present, incompletely immunized, belonging to a upper lower socioeconomic class, would be a case of cyanotic congenital heart disease with increased pulmonary blood flow with congestive cardiac failure.
Dr. Rahul, would you like to ask something?
Yes, I wanted to thank you, Vinit. But
Yes,
just to start with, presenting complaints, you mentioned there is some cough and fever
yes, sir.
with which patient has presented to you.
Yes, sir.
So when we are presenting a case, so now cyanosis you mentioned only in the later part of your history.
Yes, sir.
So whether it is a central cyanosis or peripheral cyanosis, can I say, like, based on your history, whether it is a just respiratory case and acrocyanosis?
So there is history of bluish discoloration of lips present since birth that tells us that it was a central cyanosis, and so not peripheral cyanosis. And a mother, yes, sir.
So in the exams, particularly, whenever we are presenting a case, like, which will be our at the end of our history and examination, we should come to a provisional diagnosis for that patient. So
Okay.
and then we have to make a story out of it, and we should be at the provisional diagnosis. So cough, cold, and fever, like these symptoms, when you like, you can add certain things if you notice that it is important in your final diagnosis. So
Yes, sir.
maybe when you are at the end of history, if you are finding that cyanosis was important, so
Yes,
maybe
sir.
you can put some emphasis on cyanosis in your presenting history.
Yes, sir.
Okay. And like other things, like difficulty in feeding and inconsolable or poor weight gain, that can also be added in the presenting complaints if you find
Yes.
those complaints are important, and then give emphasis to those complaints, which will lead you to the diagnosis.
Yes, sir.
Okay. And that suck cycle also, you have to elaborate little bit, like from when it began. Like you have mentioned that it is from after 1 month of 1 month of age, but you can elaborate little bit. Secondly, I just wanted to point out that when you are telling about the negative history you have mentioned, like no history of many things. So
Yes.
it should be related to our case, and first symptoms related to the system with which the patient is presenting to you. Like you have mentioned a lot of things like seizures, or urinary complaints like decreased urine output or unconsciousness. Had it been so important, those complaints will be presenting complaints, right?
Yes.
Related to that system. So we have to make sure that we are going into our final diagnosis, and like negative history should be specific, like any symptoms, more symptoms related to the same system. Like if it is a cardiovascular case, then you have to ask the symptoms related to cardiovascular system. Then any complications related to cardiovascular system, and
Yes.
then ask for any significant other histories, like maybe frequent hospitalizations because of respiratory infections. Those things should be asked. Okay.
Yes.
Dr. Vinit, I have a comment from Dr. Pramod Kulkarni. Sir is asking if the mother noticed that the child had some baseline, fast breathing or any sweating on the forehead. So was this there? Because this would be important, right?
Yes, sir. So
So was
mother
it
gave,
there?
yes, sir. Mother gave history of succress suck cycle also, and also there was forehead sweating present, which was increased since last 2 days due to which the child was not able to feed, sir.
So I think that is a very important positive history,
Yes,
which
sir.
should come in your presentation. What about the baby being baseline tachypneic or having increased respiratory movements? Baseline. We know that
Uh,
in the last 2 days the child is breathing faster than usual,
yes,
but
sir.
did the mother notice that in the last 5 months the child was breathing faster than maybe other siblings or maybe other children? Has she noticed anything like that?
Mother did not give history at first, sir, but on asking, there was fast breathing present, but which was increased since last 1 day only.
No, but there was fast breathing even before the child got sick and was brought to you. So I
Yes.
think that again is an important history. Can you tell us why there is a suck cycle and why there is forehead sweating?
Sir, these are all signs of congestive cardiac failure, sir. Whenever child is fatigued, in between, their child gets fatigued whenever he tries to feed, sir. So therefore, the child stops in between and restarts feeding. And also there is the suck is not powerful enough. So child is fatigued in between. So therefore, there is suck rest and suck cycle again. Matlab, child stops and start again.
What about sweating on the forehead? What does that tell you?
Sweating on the forehead is also is due to um, it is also a sign of congestive cardiac failure, sir, with uh, autonomic dysfunctions present at the time.
Which autonomic dysfunction? What do you mean by dysfunction?
Uh,
What is happening?
there is increased sympathetic uh, due to
Activity.
activity, which will lead to forehead sweating and increased tachypnea and increased heart rate.
Correct. So primarily to increase the cardiac output, the sympathetic system has become active,
Yes,
and
sir.
as a side effect, you will get the forehead sweating,
Yes,
isn't
sir.
it? Can you get this suck cycle in respiratory disease? For example, have a suck cycle?
Uh, so in pneumonia, there is tachypnea present. So therefore, there could be but sir, there would be a child will not be fatigued, sir. Or child is sick enough to not feed only, sir, in that pneumonia.
Classically, we say that suck cycle is a feature of a
Cardiac,
congestive cardiac failure.
congestive
Okay,
cardiac.
so exactly suck does not happen in a pneumonia. Okay, so
Yes,
it
sir.
is something unique to an heart disease. Okay, now why are we saying this is a heart disease? To me, this is a severe bronchiolitis. If you
Uh,
ignore that 1 month history of cyanosis, this child has cough, cold, fever. He's the right age for bronchiolitis. He's got
yes, sir.
severe bronchiolitis.
But sir, there is bluish discoloration of lips present since birth only. There is suppressed suck cycle again tells us about cardiac cause, sir. And also there is poor weight gain present. So that also tells us about that this is a cardiac case more than a acute case, sir. It is a chronic
So,
thing happening.
correct. So we know now from the past history that this has been going on for some time. This is not something that started 2 days ago. The
Yes, sir.
symptoms might have been aggravated 2 days ago, but the
Yes, sir.
symptoms started much earlier than that. So
Yes,
this becomes a subacute chronic problem. And why it is localizing to cardiovascular system is because there is sweating over the forehead, there is
for
bluish
suck.
discoloration of the
Yes, sir.
lips, okay, and tachypnea or fast breathing is there.
Yes,
Okay, can you go back to your slides from the first slide?
yes, sir.
Okay, can you go to the? You said this child is born of a non-consanguineous union.
Yes, sir.
What is the impact of this statement?
Sorry, sir.
Why do
Non.
you ask whether there is a non-consanguineous marriage or a consanguineous marriage? Why do you want
So
to know?
So consanguinity is important as some cardiac diseases are common in families, and also in some syndromes are associated with consanguinity, sir. Uh, there is presence, like heart disease can be present in chromosomal abnormalities like Down syndrome, and also trisomies like 18, Patau and Edward syndrome. So consanguinity is important thing to ask.
Normally,
How is Down
normally
syndrome
how is
inherited?
Sorry, sir.
Is it autosomal recessive condition Down syndrome?
Uh, no, it is a trisomy 21, sir.
Yeah. So not for that. What are you asking for? When you say consanguinity, what are you looking for? Which are the diseases where heart disease is more common with consanguinity? Which diseases are you looking at?
Um, mm, syndromes. Some syndromes such as Apert syndrome is there. Um, William.
how are the heart diseases transmitted? Congenital heart disease.
Uh,
What is the inheritance? The multivariate inheritance means not only genes but other factors also very important. So, you ask that history is a part of history maybe, but other factors will also be important in transmission of heart diseases.
Yeah, if consanguinity is there, there is 1.8 times more risk of having a baby with a heart disease. Okay,
heart disease.
And it is multifactorial, as sir said, it is multifactorial in origin. Okay, so you cannot pinpoint genetic abnormality every time. Okay, but you should know the syndromes that are associated with heart disease. You rightly said that Down syndrome is associated with congenital heart disease. Like this, can you tell us other syndromes that are associated with heart disease?
Yes, sir. There is Down syndrome is associated. Then Noonan and Noonan syndrome is present. Turner syndrome is present with pulmonary stenosis. There is Williams syndrome present, sir, with aortic stenosis. There is Alagille syndrome is present with
Very good.
pulmonary stenosis.
Very good. Okay. How do you differentiate cardiac breathlessness from respiratory breathlessness?
Sir, cardiac breathlessness will be there would be more in cardiac breathlessness there would be increased amount of intercostal retractions, more respiratory efforts present in respiratory illnesses, and in cardiac it is less amount. Cyanosis is more present in cardiac illness than respiratory illness. Uh, Tachypnea.
Tachypnea will be present in both, isn't it?
Both, sir. Signs of congestive cardiac failure will be present in cardiac breathlessness, sir. That is hepatomegaly will be present more in cardiac illnesses. Then crepitations will be present in both, but more pronounced in respiratory cause. Thus, it will the
Okay. All right. Go to the next slide, please. Dr. Rahul, you want to ask something on this slide?
Vinit, do you know the Ross classification for the congestive heart failure, like in infants? Like NYHA classification is there for the adults. There is a Ross classification based on the symptoms in infants and less than 2 years.
Yes. So in Ross classification, class 1, the child is normal. Means there is in class 2, sir, there could be minimal tachypnea and diaphoresis present on normal activity. In class 3, there would be marked tachypnea and diaphoresis seen on normal activity, and in stage 4 there the symptoms, that is tachypnea and diaphoresis, are at rest also, rest only.
Yes, tachypnea distress is at rest. So
Yes.
in the presenting illness, while describing your symptoms, you can grade the level of symptoms, and you can tell that
Yes, sir.
the basal, like initially when it started, the level was this, and either it is progressive, it is static, or it is decreasing. Those symptoms you should present in the history of presenting illness.
Yes.
So
So
can you
again,
go to the next
as
slide?
I mentioned, you have to bring in the important symptoms in your presenting complaints. Cough, cold, fever, anybody will think of the respiratory pathology, but also you have to
Yes, sir.
mention about the failure to thrive, and symptoms like cyanosis and feeding difficulty as a presenting complaints in cardiac care.
Yes.
Go. Okay, sir told you that whatever is relevant to your case you keep,
Yes, sir.
and if this child had a seizure, I'm sure he would come to you for a seizure, not for a breathlessness maybe. So yeah,
Yes.
relevant. Next. Okay.
History suggests a cyanotic spell, you asked.
Yes,
As
sir.
in,
There is no history of history currently present of cyanotic spell, sir. As baby, there is no complaint that there is aggravation of cyanosis present on excessive crying, and also tachypnea increasing on crying, sir. So this was not present.
The cyanotic spell.
Yes, sir.
Cyanotic spell, can you describe how it occurs in cyanotic heart diseases?
So cyanotic spells occur due to decreased pulmonary blood flow. Sir, it occurs whenever there is increased uh, systemic vascular resistance, due to which an excessive crying, which causes increased right to left shunting of the blood, which will increase the cyanosis. This shunting will cause
It
increased
is
cyanosis, sir.
decrease systemic vascular resistance because
Decrease. Yes, sir. Decreased
decrease.
systemic. Yes, sir. Sorry, decreased systemic vascular resistance. So therefore, increase in right to left shunt, which will cause hypoxia, hypocarbia, and hypercarbia, and metabolic acidosis. This hypoxia will lead to it will again stimulate the respiratory center and cause hyperapnea, sir. Hyperapnea, and which will again lead to increase in right to left shunt. So this cycle continues, and patient is more and more cyanosed with excessive
Right.
crying.
Right. So your symptoms are not suggestive of the decreased pulmonary blood flow. On one
Yes.
hand, a patient is having symptoms related to failure
Yes.
and with the cyanosis.
Yes.
And based on that, you don't have any significant past history, no hospitalizations for the same.
Yes, sir.
Okay. So how will you summarize at the end of, and there is no antenatal history also, which is significant, like medications. Now,
No, sir.
what are the medications which can cause cardiac defects in
Mother. Sir, if mother is taking anti-epileptics like sodium valproate, and phenytoin, sodium valproate can cause coarctation of aorta, so pulmonary stenosis. If she's taking phenytoin, it can cause pulmonary stenosis, ASD, VSD. Then lithium, antipsychotics like lithium can cause Epstein's
antipsychotics?
anomaly. Epstein's anomaly. Then estrogen and progesterone can also lead to tetralogy of Fallot and VSD, sir. Then
When is the
amphetamines.
important period for these medications?
In first trimester, sir.
First trimester. That is the period of organogenesis.
Yes, sir.
So during first trimester, any history of medication, any history of infection,
Yes, sir.
especially viral infection, is important in the
Yes, sir.
history.
Yes, sir. Infections such
Sir
as
is, yeah. Sir is
infections such as
asking, what is the likelihood of genetic or syndromic cause in this case, Dr. Pramod sir? What do you think? Is it very likely that this child has a syndrome or a genetic problem? Based on your history, we have not examined the child.
yes, sir. Because likely antenatal scans were not done, and there is no history of fever, rash, or any drug intake at such, sir, and any illness also, major illness. But we cannot rule out on history only because the scans, antenatal scans were not done, and also there is iron and folic acid supplements were not taken at the time, so there is no.
Can you ask the parents any questions that will reveal, whether the child is having a syndrome, or what on history can tell you that this is part of a syndrome?
Uh,
Suppose there was developmental delay.
yes, sir. Developmental history on
No,
history.
here it is normal. I am
Yes,
asking
sir.
you. Suppose there was developmental delay, then you could say that this is a multi-system problem.
Yes, sir.
So if there's more than one system involved, it could have a genetic basis.
Yes, sir.
It's not necessary, but it may have a genetic basis, isn't it?
Yes, sir.
You can also ask the parents, how is the child to look at? Does he look like his father, his mother? Whom does he look like? If they say, the baby looks very different, if there are obvious anomalies, the mother and the father also will pick it up. But
Yes, sir.
you could always ask the parents, does the baby look normal to you, or how does the baby look to you? These are
Yes.
some of the questions you could ask. Okay, go ahead.
Vineet, Dr. Pramod Kulkarni sir is asking which type of cyanotic congenital heart disease is likely in this case.
So because there is a cyanosis present since birth, sir, and more of along with congestive cardiac failure. So it could be cyanotic heart disease with increased pulmonary blood flow, sir, like the transposition of great arteries and total anomalous pulmonary venous connections. There could be persistent truncus arteriosus can be present, or single atrium or ventricle. These are more likely, sir.
So you should not say transposition as a first diagnosis, because in transposition there is a severe usually the cyanosis is very significant. So
Yes.
it has to be a lesion where there is a good mixing of the blood.
Yes.
So in these cases, usually, like you mentioned, single ventricle, but single ventricle with good mixing of the blood
Mixing.
is
Yes.
more likely. Transposition usually have very severe cyanosis and they present very early.
Yes.
Dr. Vinith, can you tell us the age of presentation of common congenital heart diseases? This is a common exam question, so I'm asking you.
Yes. So if child present with cyanosis on day of life, first week of life, like first 24 to 48 hours, it is more likely the transposition of great arteries, total anomalous pulmonary venous connection, then truncus arteriosus can be present, then mixing anomalies like a single ventricle and with single ventricle, and also if uh, tetralogy of Fallot with severe pulmonary stenosis, that is pulmonary atresia, can also present on first week of life. If the patient presents on 3rd to 6 weeks of life, it is more likely a decreased pulmonary blood flow condition, like tetralogy of Fallot can be there, Epstein's anomaly can be there, then DORV with pulmonary stenosis, then uh, and single ventricle with pulmonary stenosis. This can be present on day 3rd to 6 months of life. And if the child presents after 2 years, it is more likely a ICN minimization with the large shunt, like VSD with ICN, ASD with ICN minimization. Yes, sir.
Out of
Dr. Vijay,
yes, sir.
sorry.
Continue. Sir, continue.
No, Dr. Vijay, any questions from your side on this?
Yeah, as this baby is a preterm and
Yes, sir.
having a low birth weight, any other possibility of entertaining is the cyanotic heart disease with regard to birth weight?
So low birth weight childs are more common for cardiac anomalies, sir. So like PDA can be present in low birth weight child. Also, the low birth weight childs are more prone for septal anomalies like VSD, ASDs.
Any infection which can cause low
Infection.
birth weight also and heart
Yes, sir.
disease also.
Heart
Which
disease.
infection?
Yes, sir. Sorry. There is rubella, which causes congenital rubella syndrome, which also causes low birth weight and PDA PDA and in this child.
Yes. If birth weight would have been, say, large for gestation age babies,
Then
what are the possibilities?
mother could have diabetes, gestational diabetes present, sir. That GDM babies, which are large for gestational age, are prone to have VSD and HOCM and transpositions of great arteries.
Exactly. If it's LGA and with consent to your case, TGA would have been
Yes.
the appropriate thing for you. Yes. Continue.
Dr. Vinit, Pramod Kulkarni sir wants to know which syndromes are associated with conotruncal anomaly.
Syndromes with conotruncal anomalies. So, conotruncal anomalies such as TOF, sir, more common is there is Digeorge syndrome associated with conotruncal anomalies, sir. That's then there is Alagille syndrome. Then golden hour syndrome is present, sir. Then Apert syndrome is there. Then Cornelia de Lange syndrome is there.
Most common is Digeorge and others are
Digeorge.
Okay, go ahead. You said there is poor weight gain. What could be the reason for the poor weight gain?
Sir, one is that there is sucrase cycle and improper feeding, which is causing calorie deficit child, and also there is tachypnea present since birth, which could lead to excessive
So more calories are required,
calories.
isn't it?
Yes,
The
sir.
child is
Excessive
tachypnea.
calorie intake. Yes, sir.
There is tissue hypoxia also. So the child actually needs more calories, but is not able to take those many calories.
Yes.
Okay, go ahead. Go ahead. All right, go ahead. Okay, so here development is normal, isn't it?
Yes, sir.
Okay. Can you go to the summary of the case and maybe our experts can comment on how to present the summary.
Yes, sir. So summary of my case is 5-month-old male, 5-month-old female child born of a non-consanguineous marriage, firstborn with complaints of cough, fever, and increased respiratory effort since last 2 days, cyanosis since birth, history of suck cycle present, incompletely immunized and belonging to a upper-lower socioeconomic class. It could be a case of cyanotic congenital heart disease with increased pulmonary blood flow with congestive cardiac failure.
Okay. Any changes in this, Dr. Saraf? You would like to, or this is okay?
This looks okay. If you have to summarize in one line, like 5 months old female of non-consanguineous marriage, born of non-consanguineous marriage with history suggestive of fatigue or dyspnea on exertion with cyanosis and with respiratory infection.
Yes,
that will be one thing, and then probably a cyanotic heart disease with increased pulmonary blood flow with congestive heart failure, as you mentioned.
Okay,
Sir,
we can go to
Summarize
yeah,
your
sorry.
interpretation from the symptoms. What is your interpretation like based on the history?
yes, sir.
Dr. Saraf, I am Madhu Otiu.
Yes, ma'am.
Should we be adding that without any cyanotic spell, with failure to thrive, etc., since it's at the end of the summary?
Cyanotic spells, if there is that history is there, we can add. Here, if there is significant
It's an important
history of
negative
cyanosis which
point
parents
to
are
be
giving.
mentioned in the summary.
Negative history, I think he has mentioned few points, but again, there is no need if it is just a summary, what he is presenting, what he is thinking.
Okay.
Can you
Go
put
ahead,
just a minute?
Yes, sir.
Vinit,
Yes, sir.
see, you have put a differential, the cyanotic congenital heart disease with increased pulmonary blood flow with congestive heart. Can you put 1, 2, 3 depending on when it presented and all that? So, which are the diseases you are concerning? That also can be added to the summary. Differential
Okay.
diagnosis, of course.
Yes, sir. So,
So based on the probability and based on the symptoms, you can say, like sir has mentioned, likely 1, 2, 3. I would like to go with this 3 conditions.
yes, sir. So, TAPVC, mixing lesion second, and TGA third.
The cyanosis is mild, no?
Yes,
Just
sir.
now we
No,
discussed.
no TGA. No. TAPVC and mixing lesion like a single ventricle can be.
Okay, go ahead to the examination,
Truncus
please.
is also a possibility in this.
Yes, sir. Truncus arteriosus. Yes, sir. Sorry. On general examination, child is lying in supine position, conscious, alert, and irritable. Vitals: patient was afebrile, 98.4 degree Fahrenheit. Heart rate is 150 per minute. Pulse is regular in rhythm, normal in force and volume. No radioradial or no radiofemoral delay. All centrals and peripheral pulses were well felt. Respiratory rate was 68 per minute and abdominothoracic. There were presence of subcostal and intercostal retractions. SpO2, when taken off O2, it was around 68 to 17 all 4 limbs, sir. And on 5 liters of oxygen, it went around 80 to 82 present in all 4 limbs, sir. And blood pressure in all 4 limbs was around 50th percentile of the child for the age. On general examination, continued, nail bed cyanosis were present in all 4 limbs present, and lip cyanosis was present. Clubbing was present in all.
Can you tell us, sorry to interrupt you, can you tell us with what device did we give 5 liters of oxygen?
Ma'am, nasal, we started with nasal prong.
Because in nasal prong, we normally don't give more than 2 to 3 liters.
2 liters. 2 liters is good.
So which device did we use and why it is important?
We can use HFNC, ma'am. Which yes, sir. Which can it will increase saturation also.
So because different devices give different amount of FiO2.
Yes, sir.
Like we all know that. If we use nasal prongs and we give around 2 to 3 liters, it is not more than 30% FiO2.
Ma'am, O2 hood can be given. It can give 100%.
O2 hood, generally it's a high flow kind of a device.
Yes.
We generally give high amount of oxygen so that, you know, we can give FiO2 can go up to around 80-90% also if properly used. Then the simple mask won't give more than 4 liters for 40% FiO2. Simple mask, while
Yes,
the NRM will give around 100%.
NRM.
I'm only sensitizing you. You are a student. It is okay not to know, but Generally, these are the things which are important even in pulse.
Yes, ma'am.
Go ahead.
Clubbing was present in all 4 limbs. It was grade 2. No icterus, no lymphadenopathy, no edema or pallor were present. On head-to-toe examination, hair were sparse and non-lustrous. Anterior fontanelle was at level and it was 1.2 centimeter into 1 centimeter. Posterior fontanelle was closed. Eyes were normal. Low set ears were present. Philtrum normal. No cleft lip or palate present. There was presence of dorsal dermal sinus, which was 0.5 centimeter deep and 3 centimeter away from the anal opening, and no discharge was seen. Anal opening was normal. Child was syndromic. They were syndactyly present. There was a lesion present. It was ill-defined erythematous plaque-like lesion present on arm, foot, and body. It was scaly, and also there was presence of right bifid foot. On anthropometry, length of the child was 53
What does
centimeters.
that tell you, Dr. Vinith? You showed us some photographs.
Yes, sir.
What is the what do you want to say when you say syndactyly is present, bifid foot is present?
That
What
it is
are you trying to
associated.
convey?
It is associated. The child has some sort of syndrome, sir, genetic or chromosomal, which will require further evaluation.
Correct. Okay.
Anthropometry wise, length of the child was 53 centimeter, which was less than first percentile for expected of 63 centimeters. Height is weight is 2.5 kg, which was less than first percentile again. Expected is around 5 kg. Head circumference was 34 centimeter, that is microcephaly was also present. So failure to thrive was present. Systemic
So
examination.
this baby is significantly malnourished and syndromic.
Yes, sir.
So what are the syndromes
How did you
associated
check?
with limb
Yeah.
abnormalities?
Sorry, sir.
Syndromes associated with limb abnormalities like syndactyly or bifid
There
foot.
are Appert's syndrome is associated with syndactyly, sir. Then
Primarily here you are looking at heart
Yeah.
disease with limb anomalies.
okay.
Which ones are there?
Uh, uh,
Holter-arm is one which can present.
Holter-arm. Yes, sir. Yes, sir.
That is-
Holter-arm syndrome. ASD with absent radar. Yes, sir.
Go ahead.
On cardiovascular examination, on inspection, baby was inspected in supine position. Chest shape was normal. No bulging was seen. No precordial pulsation seen. No scars or sinuses seen. Apical impulse maximum below the level of nipple areola complex on the left side and was located in mid clavicular line. On palpation, apical bit, the location was
I have
confirmed.
asked for
In,
Sorry, sir.
am I audible? Okay.
Yes, sir.
So when you are saying that you are suspecting heart disease with increased pulmonary blood flow, and
Yes, sir.
you don't have any precordial pulsations, there is no hyperdynamic precordium, your apex impulse is also in the mid-clavicular line, there is no cardiomegaly which suggests this. So that is not matching with your history. So usually with this failure to thrive, because child is just 2.5 kg is vested, his chest wall is going to be very thin. And in that case, with the increased pulmonary blood flow, there has to have some degree of cardiomegaly. You will notice extra pulsations. You will see there can be heave also, which is visible. So which is not matching with your history.
Yes, sir.
And even in cardiac, like apex beat where you are locating is mid-clavicular. So that has to be also seen properly to notice that whether there is cardiomegaly is there or not.
Yes.
Because based on the history and examination, because severely wasted child, it will be very easily visible also in this scenario.
Yes, sir.
And bulging is also will be there because usually any disease with the increased pulmonary blood flow will have cardiomegaly, and there
Yes.
will be some sort of bulging because it is a chronic 5 months history. Okay, so you
Yes.
can go ahead with next.
So apical beat was present, confirmed in fifth intercostal space along the midclavicular line only. There was thrill present in the second and third left intercostal space, and no parasternal heave present and no diastolic shock.
So apex beat has to be defined more clearly how it is the apex, where it is exactly on based on inspection, and then you have to confirm with the palpation that it is in this intercostal space outside the midclavicular line inside. And what is the nature of the apex? Certain heart diseases have very peculiar type of apex which is palpable, apex beat which is palpable. Like
Yes.
tapping apex is present in mitral
Mitral
stenosis.
stenosis.
Yes. So that has to be described in a detail, like what sort of, and that will give a clue towards particular diagnosis as well. RV apex or LV apex, that has to be mentioned in the examination, whether it was right ventricular type of apex or left ventricular type of. And just go back that there is no parasternal heave and there is no diastolic shock. What is diastolic shock?
It is palpable P2, sir, present in the second intercostal space. It signifies pulmonary artery hypertension. It is present in pulmonary artery hypertension.
Okay. Any other pulsations which were palpable apart from the apex beat?
So there was thrill present in second and third intercostal space, sir.
Yes, because many of the heart diseases, sometimes they can have Malpo's great arteries like DORB.
Yes, sir.
DORBs and all, and in that case, there can be palpable other sounds as well. Again, in the cardiac failure part also, there can be palpable S3 or S4 also
Yes, sir.
seen in certain cases or felt in certain cases. Okay?
Yes, sir.
So what is your comment depending on the location of apex beat, Vinay?
So that there is no cardiomegaly present at this moment, sir. At this time, there is. It is in fifth intercostal space.
Yes, child is 5 months old, so you can take it as a cardiomegaly. It is in the fifth intercostal
Yes,
space
oh,
as you
yes,
examine.
Fourth
Only thing is, you have to re-examine to see whether there is parasternal heave and diastolic shock both. And also, as sir told, you have to be very specific with the apex beat, how it is the character and all that thing. So that has to be told in the apex beat. And as you told thrill, is it systolic or diastolic?
Systolic, sir.
Is coinciding with apex beat.
Yes, sir.
Okay.
Second, third intercostal space. Yes, sir. On auscultation, heart sounds are S1 heart sounds S1 S2 present in all the area of heart and best heard at left upper sternal border. Grade 4 systolic murmur. It was a loud, harsh ejection systolic murmur in nature. Best heard at left upper sternal border and was radiating to back and axilla.
You have to describe heart sounds in very much details. S1 and S2, just S1 and S2 is a very important feature in examination. And there can be a class on S2 second heart sound, how it is played, whether it is single. So that has to be in very much detail. And you have to also mention that whether there are any S3 and S4 which are present, any gallop rhythm which is there, or it is absent, because this is not fitting with your provisional diagnosis at the end of history.
Yes.
Okay.
So you have to describe in each area actually.
Yes, yes.
Yes, sir.
You cannot just tell ki heart sounds are normal and that. You have to describe mitral area, the pulmonary area, aortic area, tricuspid area. So as per the protocols laid down for auscultation, you have to present like that. And each area may
murmur has
be.
to be, yes, sir. As you mentioned,
Yes,
murmur
please
has
go ahead.
to mention which intercostal spaces you are hearing the best, like not only
Second.
left upper sternal border, but which
It was
intercostal.
present in second intercostal space, sir. Just lateral to the upper sternum or sternum, left side.
Yes, so it has to become with the detail grade of the murmur.
Four.
Also, no diastolic murmur, no S3, S4. That has to be standard in cardiac cases.
Yes.
Not in other cases. When you are presenting a cardiac case, it has to be with all the parameters which are included. And of course, here also you can mention if it is absent, no S3 and no S4.
Yes.
Whenever there is a failure, usually patients will have third heart sound and
Third outside. Yes.
gallop rhythm.
Yes.
And if it is absent, that means child is more stable, but your respiratory rate is 68. So child is in failure, but your examination is not showing those parameters here.
Yes.
Okay. So
Yes.
next.
Did you mention about epigastric pulsations? I don't remember. Maybe I missed.
No,
I've written no other pulsations present. No, I've not written epigastric pulsation.
Okay.
Any clicks? Any?
Sir, I could not hear any clicks, sir. That's such.
How will you differentiate from innocent murmur from organic murmur? Suppose from periphery patient referred with murmur.
Yes, sir.
How will you, because each and every baby we can't go for echo. So we have
Yes,
to
sir.
screen and we have to do echo. So which are the features of innocent murmur?
So innocent murmur are those which there is a murmur present without any functional or anatomic cause. There should be the murmur is usually less than grade 3 systolic murmur. It is present with normal cardiac silhouette, normal X-ray, normal ECG, normal heart sounds. No cyanosis should be present, and it is systolic. It is systolic murmur, not a diastolic murmur. These are features of innocent murmur.
Okay.
The respiratory system. On inspection, trachea is central. Chest movements were bilaterally equal, but intercostal retractions were present and subcostal retractions were also present. On palpation, inspection findings were confirmed. Bilateral chest expansion was equal. On percussion, there was resonant note present. On auscultation, there was bilateral basal crepitations present. For abdominal examination, abdomen was soft, non-tender. Liver was palpable 2 centimeter below the costal margin, but liver span was normal. That was 5.5 centimeter, and no other organomegaly. So my provisional diagnosis is cyanotic congenital heart disease with increased pulmonary blood flow in congestive cardiac failure without infective endocarditis in a syndromic child but developmentally normal child.
So that increased pulmonary blood flow, that features you should mention on your examination, which are lacking your physical examination. Okay. S3, I mean, not only auscultation, but also on the inspection and palpation. Because history was suggestive of increased pulmonary blood flow, but in the examination part, you have not mentioned that. That indicates it is a like either normal pulmonary blood flow or decreased pulmonary blood. So that contradiction should be avoided.
Yes.
What about liver? How big was liver?
It was liver span was 5.5 centimeters, ma'am, and but liver was palpable 2 centimeter below postal limit.
It is normal for this age, no?
Yes, ma'am.
So there was no hepatomegaly also.
No, ma'am.
Hmm. So why are we calling it CCF?
Because other features of CCF are say present, like failure to thrive and suppressive cycle is present. Then there is crepitations also present, increased tachypnea, tachycardia is present. Only hepatomegaly was not. On investigation, hemogram was done in which HB was hemoglobin was 15.7 gram per deciliter, and
So what are the investigations you would like to do in this case?
I would like to do a complete blood count, sir, in which I would look at hemoglobin of
No,
this patient.
I'm asking you relevant investigations.
Okay, I will do a chest X-ray, sir, to find out
What will expect
cardiomegaly.
you will expect on the chest X-ray?
There would be a cardiomegaly with pulmonary plethora, sir, would be present. Also,
Can you show us the X-ray in this child?
yes, sir. This was the X-ray. There was cardiomegaly so present. CT ratio was 0.6, and there was increased pulmonary plethora.
Describe this X-ray. How will you describe?
This is a chest radiograph, posterior anterior view, well centralized, with trachea in center. With
It will be AP view. In usually children, they because he took it supine position, it will be AP view. And see the spine. Spine is more prominent.
yes, with there is cardiomegaly present, sir, with CT ratio of 0.6 present. There is increased
Is it a LVFX or RVFX?
it is more going downwards and outwards, sir. So more of a LVFX, LVFX, sir.
Yes. And describe
And
each thing, like you have to come from either from outside to inside or inside to outside. Well centralized and
well
then
centralized trachea is in center, sir.
you have to finish the cardiac part, then go into the lung part, and then in the bony structures.
It is well centralized. Trachea is in center, with cardiomegaly present with apex shifted downwards and outwards, and with there is pulmonary multiple. There is increased pulmonary plethora present.
Left heart border is straight.
Yes, sir.
Can you please tell what is the left heart border made up of and right heart border made up of?
Right heart border is made up of right atrium only, and left heart border is made up of left atrium, left ventricle, and apex.
Right heart border is only right atrium.
And superior and inferior vena cavas, major vessels, and also yes.
So left heart border, what is the highest point made up of?
Pulmonary artery.
What is above that in normal heart?
Arch of aorta.
So aortic knuckle is the,
Yes, sir.
what is
Left
below that?
aortic knuckle, then pulmonary veins.
Pulmonary conus, left
Conus,
atrium,
left
appendage,
atrium,
the left ventricle,
left
right?
ventricle. Yes.
Ah, ah. So when do we see straightening? What contributes to the straightening of the left heart border?
Straightening of left heart border is seen in there is mitral stenosis and
These structures, which would normally give a little bit of concavity, are enlarged or
yes,
are
ma'am.
bigger. So that will that will contribute to the
Left straightening.
Hmm.
So left atrial enlargement, then
Back to Dr. Saraf sir's patient question.
yes,
No, I was just mentioning that, as madam said, that dilatation of those portions will cause concavity, will cause that straightening. So MPA enlargement and the LA enlargement, the condition which
LA.
will cause them will cause the straightening of the left heart border.
Yes. So mitral stenosis could be a reason of left border straightening.
In
Then
pediatric, it is very rare, mitral
yes.
stenosis. So more common is the lesions with left to right shunt with increased pulmonary blood flow. They can cause left heart border
Okay.
straightening.
Yes.
Okay, continue.
I'd like to do a ECG also, sir. In ECG, there was tachycardia was present. RR interval was around 150 per minute, sir. There was right axis deviation present, seen in first and AVF. The V1 in V1 and V2, there was large R waves present, which is suggestive of right ventricular hypertrophy. Echocardiography of this patient was done. There was presence of C.
How do you decide whether it is normal right ventricle or there is a hypertrophy? How do you decide? What are the criteria to say that this is hypertrophy, this is normal?
In ECG, sir.
Yeah.
Yes, sir. Presence of tall R waves in V1, V2, sir. Then that is more than 10
So what
boxes.
ratio will you use? There is some ratio. That is very crude way actually, but still. RS ratio.
R wave in RS ratio, S wave in V6 and R wave in V1, sir.
Rahul sir, can you little bit enlighten us about this?
Actually, there are age-specific criteria also,
Norms, yeah,
and
yeah.
those nomograms are available, and we can compare the height of R waves and whether it is normal or enlarged. So that can, I mean, that can be kept in our wards, and then we can see whether there is any increased forces. So R wave in V1 and S wave in V6. That is. And all the
Correct,
nomograms
RS
are
ratio.
age specific, like 3 months, 3 to 1 year, and then 1 to 6 years. Like they are age specific.
And as far as I have seen in that Park and New, the range of these normal values is so much, so wide. So it is very difficult to remember it. As Rahul says that we need to have it at the bedside available like growth charts,
Yeah, like growth charts.
In this case, if I see AVR, S is equal to R. So the axis has to be exactly perpendicular to this. So
Yes.
which
Yes.
means it is likely to be 30 degrees. 190 plus 30, around 120 degrees.
120.
Rahul, am I right?
Yes.
Yes, ma'am. Yes, ma'am.
It's 120 degrees at 5 months. Is it okay, or it's
It is quite, I mean, right axis deviation.
Acceptable.
So you have to also know the conditions which present with such type of ECGs. When you ask for investigation, you should also know that what you are expecting from that result, or what you are supposed to know from that result.
Yes, sir.
You should know what are the common, patterns of ECG for example, in ASD, in a large VSD, in a moderate VSD, in a TOF, in Epstein's anomaly. What are the classical ECG patterns for common conditions? Not, if there is a complicated heart disease, then it's another story. But for say 70-80% of the conditions, you should know what are the typical ECG findings. Okay, so that is important.
Yes.
I think here 3 things matter. One is that it's 120 degrees. Second is Q wave in the right-sided leads. And the third one, I think, is R wave, R and S in V1 and V6. I'm not very sure. V1, V2 shows very tall R waves. Sometimes it also depends upon how the leads are
Placed, yes.
placed.
Especially with a small baby, the standard leads that are used cause problems.
I think we can move on.
Echocardiography of this child was done. It was suggestive of severe pulmonary stenosis with supracardiac TAPVC, and also there was large ostium secundum ASD with right to left shunt and mild right ventricular dysfunction.
Okay, do you know the types of TAPVCs?
Yes, there are four types. Sir. Supracardiac TAPVC, which is most common, sir, that all the veins enter in nominate vein or SVCs. Then there is cardiac type, sir. It opens up into coronary sinus or right atrium. Infracardiac, least common, sir, which is the veins can open into IVC, hepatic vein, or portal veins also. And there is mixed type, 4 types.
Okay. So what do you think the type of supracardiac TAPVC in this child?
It is a supracardiac TAPVC.
But it is not obstructed.
Not obstructive, non-obstructive. Obstructive and non-obstructive.
Had it
Yes.
been obstructive, significantly obstructive,
The
it would be more symptomatic and they will present very early.
Yes, sir.
Okay, what is the management? How will you manage this case?
If the management will depend on the severity of cyanosis and grade of as the child has severe pulmonary stenosis also. So if the child has presented with cyanosis at birth only, that pulmonary stenosis was severe enough. So and TAPVC, we could start this patient on as it is a duct dependent, it would be a duct dependent lesion. Then we'll start with
It is not a
prostaglandin.
duct dependent, because had it been duct dependent, it would have been duct dependent from the birth. Right?
Yes, sir. Yes, sir. In this child, we'll go for nutritional management. We'll improve the nutrition of this child. We'll go for correction of TAPVC, sir. It can be done
Medical
around 6.
management, you have to stabilize the child first.
Yes, sir.
Little diuretics.
Yes, sir. For
Because
medical
child has congestive heart failure.
Yes, sir. We can start the child on oxygen first. Then we'll start with
Usually TAPVCs
furosemide.
are isolated lesions. They do not have any associated lesions, but in this case is little unusual and there is pulmonary stenosis. But in majority of the cases, TAPVCs are isolated lesions.
Yes.
And after initial stabilization, they need corrective surgical treatment.
Yes, sir.
So here, Dr. Saraf, I would like to ask you, if we are given a child who has cyanosis and we think that this is a cyanotic congenital heart disease, so as a pediatrician, as a general pediatrician, we have only probably limited management available. So how do you decide that this child I will give propranolol and this child I will give a diuretic? So what do you look at? It's a very
Usually symptoms
simple
like
question.
if it is cyanosis with decrease, I mean, we can make out on the examination whether it is increased pulmonary blood flow or decreased pulmonary blood flow. If we are expecting decreased pulmonary blood flow, we can start on the low dose, like normal dose beta blockers. If it is PS situation, we are expecting in which the child growth will be preserved and there will be no symptoms of congestive heart failure. While on other spectrum, if the cyanosis is associated with the features, like in this case, where there is features of congestive heart failure as well, and there is cardiomegaly, plethora. Here we can give diuretics in this scenario.
What about fluid management? How will you decide how much fluid to give to this child? I think we are going more towards PICU now here, but still.
Rajesh, now here there was a severe PS. So how do you explain that increased pulmonary flow from where? Hemodynamics.
Uh,
Anyone?
That is one issue here. If we look at the
I didn't
X-ray,
get
I think,
this is
yeah,
a
It will be
genuine
like
question. I
pulmonary.
didn't get it. How it?
It will be like pulmonary venous congestion rather than arterial congestion, because more
yeah.
because of PS, the blood flow may not be going, but there will be some degree of restriction for the at the ASD level, and there can be because all the blood which is circulating into, and there will be some relative stenosis part at the ASD level. There will be some venous congestion. Secondly, many times what happens in this scenario, more blood is going towards RA and RV side, and that PS gradient gets overestimated because of the increased flow across it.
See, as I understand, all the blood from the lung is coming to the RA, correct?
Yes.
And there is a connection between RA and LA, and
Yes.
then there is a PS because the blood cannot go, enough blood cannot go into the RV. So RA is sending most of its blood to the LA, right?
yes.
So then LA is sending. I'm just trying to figure out the hemodynamics. Rahul, can you just tell us the hemodynamics in this patient? How the child has survived till 5 months?
Usually that PS part can be little overestimated because of more blood which goes across the pulmonary valve. The oxygenated blood is going to the RA, it is going to RV, and from RV it is getting pumped across the pulmonary valve. When the lot of blood goes across the pulmonary valve, which is, even if it is slightly narrow, it can overestimate the gradient in the echo. And that is one possibility. Secondly, there is mixing, there is ASD. So the circulation in both the ventricles, it is maintained. So child, I mean, even TAPVCs, sometimes the unobstructed lesions, they can survive longer than the obstructed lesions, obviously. So it is possible that because of ASD and good mixing, this child has survived.
So you are trying to tell us that the PS may not be that severe.
Yes, that is one, because
That's the crux of the matter.
yes, that is overestimated in ecos because of the more blood. It is related to the flow.
All right. Thank you for that clarification.
Go ahead, Dr. Vinit. Any other thing you want to tell us?
Yes, so that's it.
Okay. So, Dr. Rahul Saraf, I would like to ask you regarding cardiac surgery in this child. How amenable is this lesion to cardiac surgery? What is the usual age for surgery, and how is the likely outcome?
Usually, this subset has a good outcome if it is not obstructed. Usually, surgery, if it is unobstructed, we can wait for some time, but usually 3 to 6 months in unobstructed lesion. In obstructed lesions, immediately after the diagnosis, we have to operate. If the pulmonary vascular bed is well formed, venous and arterial, then outcome is good. Sometimes obstructed lesions, their native pulmonary veins and venules are very small, and that subset is difficult to manage even after the surgery. We have to initially stabilize. I mean, in obstructed, there is no time, but we have to go for directly surgery. But overall result are almost 90 to 95%. They can survive, and this is the one condition where a single stage repair can save a life for that baby. Like, it is a corrective surgery. There are certain corrective and palliative surgeries in pediatric cardiac surgeries. So this is one of the conditions, cyanotic heart disease, which can be corrected completely. Usually, when the repair is done, the anastomosis is made between the pulmonary venous confluence and the left atrium. ASD is closed, and if the anastomosis is good enough, that will grow with the child, and child doesn't require another surgery. So results are very good for the unobstructed lesions. Obstructed, it will be at least 80 to 90% if the veins and venules are well formed.
Great. So, any questions from Dr. Vijay, Dr. Uti Madam, Dr. Pramod sir?
Rahul, can you explain for the sake of postgraduates what is the exact difference in the hemodynamics of obstructed versus unobstructed?
Like in TAPVC, what is TAPVC? Is total anomalous pulmonary venous connection. Here, the pulmonary veins, they do not drain into the left atrium, but via another structure, they drain into the other part of the heart. So either it is supracardiac, cardiac, or infracardiac, or mixed type of lesion. So in supracardiac, we know it either enters left ascending vertical vein or into the right superior vena cava directly. Cardiac, we know that either through CS or directly into the RA, and infracardiac into the hepatic and IVC system it can enter. Mixed can be 2 veins here or 1 vein into the cardiac and supracardiac. Like, there can be different permutation and combination. So this is the structural classification, but functionally it can be obstructive or unobstructive. So obstruction can occur in supracardiac as well, but it is almost always there in the infracardiac. So in supracardiac, when it is going to the innominate vein via vertical vein, there can be compression between the bronchus and the pulmonary artery. It is called hemodynamic vice. And in that case, what happens is blood, which is oxygenated blood, which should reach the left atrium, it is not reaching, but there is obstruction as well. So there will be pulmonary venous congestion. And pulmonary venous congestion will lead to pulmonary arterial congestion also. There will be plethora and tachypnea, symptomatic, more symptoms. So in cardiac also, when it is entering in the coronary sinus, there can be sometimes obstruction when pulmonary vein joining the coronary sinus. Any obstructive lesions will have more symptoms, and symptoms will be related to pulmonary venous congestion. In unobstructed lesion, obviously symptoms will be less. Blood is reaching the right atrium, and from right atrium through the ASD, it is mixing and it is going into the LA and the left ventricle. So circulation is maintained. Whenever circulation is unobstructed, body gets adapt to it, and there will be subtle cyanosis, and there can be mild tachypnea which can miss, but the symptoms will be very less. In any of the types of the structural heart, like supracardiac, cardiac, ASD can be restrictive, and that is another level of obstruction in this cardiac or supracardiac TAP disease. So more the obstruction, more the symptoms. That is the rule of, and any obstructive lesion in cardiology will cause more symptoms. They will present early. Any unobstructed lesions, they will present late, comparatively late.
So can I safely say that the obstructive will not go beyond neonatal period?
It depends on the severity of obstruction.
Hmm.
If it is severely obstructed, obviously they will not survive for long. But if it is mild obstruction, they can. Usually body gets adapted to that level also. We have operated almost 3-4 months old, which is severely obstructive. It depends on individual physiology, and that child survived on the PFO, surprisingly. I mean, that can happen.
Thank you for all that detailed explanation, Rahul. One more question, hypothetical. Suppose if we do intervention and relieve PS only in this patient as the first, what may happen? Intervention, like non-invasive in
That
this
is,
patient.
I mean, hypothetically, if we relieve, but his symptoms will not get relieved because more blood still will go the pulmonary circulation, and his symptoms will remain like that.
But cyanosis will get relieved, right?
Cyanosis also, it will
Because
not
this is
change
IAP.
to a great extent, because yes, if it is severe PS and we relieve that, there can be some degree of relief, but again it is a mixing lesion. So cyanosis, if it will not go beyond certain limit. Like it will not become more than 90, 92. It will not reach that.
Agree. I think you have taught us very well. Thank you for all that.
Yeah. So very nice session. Thank you, Dr. Vinith, for this presentation. It was a little complicated case, not so straightforward like a tetralogy of Fallot or a VSD, but quite well done. And I would like to thank the mentors, Dr. Suryakant Mundlod sir and Dr. Dipali Ambike ma'am, and Dr. Oti madam. Thank you very much for your inputs. Dr. Vijay,
I was
thank you.
learning, Rajesh.
I think all of us are learning, particularly when it comes to
Good
cardiology.
input from Dr. Rahul and Madam.
Yeah.
Thank you. Thank you for
It is always learning from
inviting me for this
It is a
session.
two-way process.
Yeah. Dr. Vijay, thank you very much for being with us for this session.
Thank you, sir. Thank you for inviting me.
I thank IAP Pune for hosting this session, and we will see you in a couple of weeks again, maybe with a different system. Thank you very much. Thank you all.
Thank you. Thank you.